Welcome, and thank you for joining us for the first installment of our four-part Recreational Water National Webinar Series. I'm Christy Denbrock, Chief Learning Officer at NEHA, and I will be your moderator. This webinar focuses on recreational water illness and will cover the latest national surveillance data, what it tells us about the state of design, construction, operation, and management of U.S. public aquatic venues, and underscore the need for the Model Aquatic Health Code. Our presenters today are Michelle Halavasa, Chief of CDC Healthy Swimming Program. She has worked on multiple investigations of outbreaks of recreational water-associated illnesses and collaborated with the U.S. and international public health authorities and the aquatic sector to develop science-based prevention and control measures. She has a bachelor's degree in nursing from the College of New Jersey and a master's in public health and epidemiology from Emory University. And joining her is Dr. Tessa Clemens. Dr. Clemens is the health scientist focused on drowning prevention in the Division of Injury Prevention, National Center for Injury Prevention and Control at the CDC. She defines effective strategies for preventing drowning through investigating data resources and methods to improve drowning surveillance. Her work focuses on supporting health equity, which includes understanding and addressing racial and ethnic disparities in drowning rates and supporting the implementation and effective interventions among underserved populations with the highest rates of drowning. She has a PhD in injury epidemiology from York University and completed postdoctoral fellowship in global child health at the Hospital of Sick Children in Toronto, Canada. We ask that you please write your questions into the chat box and we will address them at the end of the presentation. And if you are not a NEHA member and enjoy this session, we invite you to become one at neha.org. Michelle, will you get us started?
Sure. Thank you, Christy. Get my slides up. All right, so, oh gosh, let's see if I can get rid of this here. Okay, so I'm going to cover healthy swimming data and how we promote healthy swimming here at CDC. So first, as Christy had said, I'm going to get into surveillance data. When it comes to cases of waterborne disease and waterborne disease outbreaks, in terms of surveillance data, all those data come to CDC via the Waterborne Disease and Outbreak Surveillance System. And so when CDC gets outbreak data, it gets those specifically for enteric illnesses through the National Outbreak Reporting System, or NORS. NORS collects data on gastrointestinal illness that results from contact with animals, person-to-person transmission, environmental contamination, or from fomites, waterborne transmission, or foodborne transmission. So I'm going to focus on the waterborne transmission. The 50 states, the District of Columbia, and the U.S. territories such as Puerto Rico all report to CDC via NORS. Now, today's talk is going to focus in the beginning on treated recreational water-associated outbreaks. So when we're talking about such outbreaks, we're talking similar illness in 2 or more persons, and these illnesses are going to be linked by location and time of exposure. Exposure could be to the recreational water itself. So in this case, when we're talking about treated recreational water, we're talking about pools, hot tubs, splash pads, where we filter the water, where we are also treating the water, whether it be with chlorine, bromine, or adding acid to get the pH where we want it to be. If it isn't exposure directly to the water itself, it is exposure to the air surrounding surrounding the recreational water venue. So it could be about aerosolized water droplets containing pathogens, such as the transmission of Legionella, which causes legionellosis, Legionnaire's disease, Pontiac fever. Or it could be volatilized chemicals, such as chloramines, coming from the water and going into the air. So the last time we looked at national surveillance data systematically, we looked at 2015 to 2019 data. Oops, sorry. And when we looked at these data for the years 2015 to 2019, we found 208 outbreaks. So of these 208 outbreaks, for these 208 outbreaks, we got reports from 36 states and DC. These 208 outbreaks resulted in at least 3,646 cases, 286 hospitalizations, and 13 deaths. And the states that were reporting, as well as DC, they are highlighted in blue in this map. In terms of outbreaks associated with treated recreational water for those 5 years, if we look at them by etiology and month, we get this histogram here. So this histogram is looking at a calendar year. So outbreaks starting in January, February, March, etc. And the blue bars in this histogram, the dark blue bars, I should say, are outbreaks that are confirmed to be caused by Cryptosporidium. The medium blue bars are outbreaks confirmed to be caused by Legionella. And the light blue bars are those outbreaks that are confirmed to be caused by something else, maybe perhaps E. coli, Giardia, or Shigella or norovirus. The striped bars do not have a confirmed etiology. So as you would expect, this histogram peaks in June, July, August. So this is what we think of as the traditional summer swim season. Memorial Day weekend, the last weekend in May through Labor Day, pretty much the first weekend in September. And we see that those blue bars are really generating the shape. So Cryptosporidium is causing most of these outbreaks, these dark blue bars, the Cryptosporidium outbreaks. We see that Legionella, represented again by the medium blue bars, those tend to start in the first half of the years, those outbreaks, that is. If we look at these outbreaks over time differently by year that the outbreak started, the year for which that outbreak was reported for, we see a slightly different picture. So we see the dark blue bars again. That's when we have a confirmed Cryptosporidium etiology for the outbreak. The medium blue bars, the confirmed Legionella etiology for the outbreak. The light blue bars, the other confirmed etiology for the outbreak, and the striped lines again are the non-confirmed outbreaks with a non-confirmed etiology. And we see that between 2015 and 2016, basically the number of outbreaks caused by Cryptosporidium doubled. Cryptosporidium tends to run a cycle where it suddenly peaks one year. Normally we see 10 to 20 outbreaks caused by Cryptosporidium in a given year. And then I would say like every 5 to 10 years, we'll see a big peak, and that'll jump closer to 40 outbreaks in a given year. We see after 2016, the number of cryptosporidiosis outbreak goes down. The number of cryptosporidiosis outbreaks goes down, but the number of outbreaks of legionellosis goes up. And that could possibly be because of improved surveillance. We are getting better and better at tracking travel-associated outbreaks caused by Legionella, for example. In terms of what we see in 19, we see a drop off in the number of treated recreational water associated outbreaks reported to CDC. We think this is an artifact. We don't think these outbreaks suddenly decrease. We think this is an artifact of reporting. Our state and local partners who report these outbreaks to us tend to report them the following year. And as we all know, in 2020, we were all dealing with the pandemic. So we were thinking that this drop we see in 2019 is more artifact as opposed to reality. When we look at the 208 outbreaks for those 5 years, as we've seen depicted in the previous slides, 155 of those 208 outbreaks, or 75% of those outbreaks, had a confirmed etiology. 76 of those outbreaks, or 49%, were caused by Cryptosporidium, resulting in at least 2,492 cases and 82 hospitalizations. Another 65 outbreaks, or 42% of the outbreaks with a confirmed etiology, were caused by Legionella. Those outbreaks caused at least 354 cases, 177 hospitalizations, and 13 deaths. So Cryptosporidium, which is resistant to chlorine, is able to cause bigger outbreaks that don't seem to be as severe in terms of hospitalizations and deaths, whereas Legionella tends to cause smaller outbreaks, but with more severe illness. You have more hospitalizations and you even have deaths. If we look at, again, at those 208 outbreaks overall, we see that about a third of them, or 34% of them, or 71 outbreaks, were associated with a lodging setting, a hotel, a motel, or resort. 50 of those 71, or 70%, were associated with hot tubs. When we look at pool chemical injury data, these data don't come from CDC, but they come from the U.S. Consumer Product Safety Commission, or CPSC. Now, we don't think about illness per se when we're talking about pool chemical injury data, but pool chemicals are really important in healthy and safe swimming in pools. They help us prevent the spread of pathogens or the transmission of pathogens in aquatic venues, as well as help keep the water clear. And so when we see pool chemical injuries, we have to look at it from the perspective of, we need pool chemicals to prevent illness, but yet we shouldn't have these injuries. So there's this balancing act of, how do we make sure we use pool chemicals safely? So the CPSC has a National Electronic Injury Surveillance System, or NICE. This is a nationally representative sample of about 100 US hospitals. And so the data is collected in these hospitals on emergency department, or ED, visits for injuries involving consumer products. So when we go to the NICE data set to look at the data, we have a product code specifically for pool chemicals. It's 938. And we can get data on the patient age, sex, where the incident or where the injury occurred, an injury diagnosis, and a narrative. The narrative is basically 2 fields of about 140 characters. So I guess we can say that CPSC throughout the last few decades started tweeting before everybody else did. In terms of methods and results, so what we did is we weighted each case based on the probability of the NICE hospital being selected, or its emergency department being selected. We took those weights and we summed them up to produce national estimates. We also calculated 95% confidence intervals for those estimates, taking into account the complex sampling design. This is all just a fancy way of saying, we said if a person presented with a pool chemical injury at this ED, they're actually representing this many people across the US just by walking into this ED. And then we said, all right, we have our estimate. We are about 95% confident that what's truly going on in the US, what's truly going on in the whole population, falls in this range. So we analyzed the data in SAS, and we calculated that for the years 2015 through 2017, an estimated 13,508 emergency department visits occurred because of pool chemical injuries. Almost 2/3 of those injuries occurred during the summer swim season. So again, Memorial Day weekend through Labor Day, which is exactly what you expect. This is what we saw with the outbreaks. This is what we're seeing with the pool chemical injuries. A lot of this is going on in June, July, and August. So this histogram here looks at the last 10 years of data in terms of the total number of emergency department visits for pool chemical injuries in a given year. So this is 2008 through 2017. We see anywhere from 3,000 or roughly 3,000 emergency department visits for pool chemical injuries a year to a little over 5,000. The median for annual estimated number of emergency department visits is about 4,535, which is depicted with the dashed lines here. The solid lines represent the 95% confidence intervals for each estimate for each year. In terms of demographics of patients we're seeing, so remember I told you earlier that we estimate there were some 13,500 emergency department visits each year. We estimate that about almost 5,000 of them were for patients 0 to 17 years old. So our less than 18-year-olds, our children and our teens. In terms of who else we're seeing in the ED for pool chemical injuries in the US, we're seeing about 2/3 of these patients are men. In terms of incident location, it looks like over half of these pool chemical injuries are occurring in the residential setting, so about 56%. Another 7% occur at a place of recreation or sports, and another 4% of other public property. 33% of the incident location reported, 35% of the reports had an unknown location. So I'm going to guess that there's going to be some more of those associated with a public setting, with, for example, a rec center pool or a community pool or a hotel pool. Thing to keep in mind when we look at NICE data, we see that individual pool chemical events, when they occur at a public aquatic venue, they tend to impact or injure more people, which makes complete sense. There's only so many people that are going to go to a backyard pool versus going to a hotel pool or to the town pool. In terms of injury diagnosis, when it comes to ED visits for pool chemical injuries, about 39% of the patients are diagnosed with poisoning. Now, when I'm talking about poisoning, I'm not only talking about ingesting pool chemicals, I'm also talking about inhaling dust, vapor, fumes, and gases. Another 28% are diagnosed with patients are diagnosed with dermatitis or conjunctivitis, so an inflammation of the skin or inflammation of the eye. Another 19% are diagnosed with chemical burns, and another 14% are diagnosed with some other diagnosis, or a diagnosis was not reported. When we look at the narratives in these reports, there are common themes that pop up. People are often getting injured when they're opening the containers for pool chemicals. So they're breathing in the dust, the vapor, the fumes or gases. Pool chemicals are being added right before swimmers are entering the water, or they're not keeping pool chemicals out of the reach of children and teens. And I really think that the take-home message from this, from these data are, these are all preventable. We shouldn't be inhaling dust if we have respirator masks. We shouldn't be getting pool chemicals in our eye if we have goggles on. So it's really important to follow the safety messages on the pool chemical label, on the safety data sheets, reading the directions on how to use them, use the pool chemicals safely. All the information is there. It's just we've got to get used to wearing the PPE. And, there has been a push to have natural pools and to not fluorinate pools. And I think some of it is that we're trying to throw the baby out with the bathwater. Yes, pool chemicals, can cause injuries, but at the same time, pool chemicals are keeping us safe from those outbreaks and from other pathogens in the water. So recently, we've had a few cases that we've consulted on here at CDC, as well as a few outbreaks. So I want to go over a couple cases and as well as an outbreak. So it seems like lately, a lot of what we've been hearing about is cases and outbreaks associated with splash pads. Now, just to make sure we're on the same page, splash pads spray or jet water on users and typically have no standing water in the user activity area. So these are basically built to all but eliminate the risk of drowning. Other names for splash pads are water playgrounds, interactive fountains, spray pads. And so when we have these splash pads, we're interacting with the water as the name interactive fountain suggests. But sometimes we use decorative fountains as if they were interactive fountains. So as far as we're concerned at CDC's, decorative fountains can also be splash pads. So when people are playing in the water, when they're cooling off in the water, when they're washing in the water, when they're getting in the water, we consider decorative fountains to be splash pads. And they should be operated and managed and such. And in this picture is probably one of our more famous splash pads here in Atlanta. These are the Olympic rings. This was originally, these were originally built as a decorative fountain. for the 1996 Olympics. People started getting into it, and luckily the city of Atlanta was pretty proactive and put filtration on it and put a different disinfection system on it. So it was pretty quickly treated. The water was treated and it was operated and managed as a public aquatic venue. Recently, we've heard of cases, or we've been working on cases of primary amoebic meningoencephalitis, or PAM, caused by Naegleria fowleri. Naegleria fowleri is commonly known as the brain-eating amoeba. And what happens is, if water containing the amoeba gets into the nose, the amoeba can travel up the olfactory nerve and into the brain, and it basically just starts digesting or liquefying the brain. We should not be seeing cases of Naegleria fowleri infection in people swimming in aquatic venues. That water is treated, it is filtered, it is chlorinated, it is brominated, whatever the case may be. We shouldn't be seeing cases of primary amoebic meningoencephalitis if we are treating the water correctly. So in 2020, a 6-year-old boy in Texas went into a decorative fountain in his community, like a lot of other kids in the community. This decorative fountain didn't have a filter on it, really, not one that you would use on a public aquatic venue, and it wasn't systematically chlorinated. The child went into the water like he did other times, like other kids have done. He developed a headache a few days later, became confused, was hospitalized, and passed away a few days later. And so he went into the water in late August, and by the first half, sometime in the first half of September, he passed away. Again, in Texas in 2021, there was a 3-year-old boy who went into an actual splash pad in his community. This was a splash pad that had animals spitting out water. He was trying to kiss the animals while he was in the water. His mom took him home because she was frustrated with telling him to stop, and he kept doing it anyway. A few days later, he developed a headache, became confused, was hospitalized, and passed away as well. Again, went into the water in late August, and had passed away the first half of September. In this case, the chlorine level was not well maintained in the splash pad, and there were debris in the collection tank. And there were some questions and issues with the construction or the plumbing, and some issues with the filtration system. So here, again, the water was not being treated well. Last year, we published with our colleagues in Kansas a report on an investigation we did in 2021 looking at gastrointestinal illness associated with a splash pad in a wildlife park. This splash pad was 5,000 square feet. As you can see from the image, it had tipping buckets, water cannons, slides, waterfalls, and fountain jets. It was designed professionally, but it was constructed by the park operator. It opened just before Labor Day in 2020 and reopened Memorial Day weekend 2021. It became pretty obvious that there was a Shigella outbreak pretty early on in the investigation, and that those patients infected with Shigella went into the splash pad on June 11th. 2 patients had Shigella flexneri identified, or Shigella flexneri type 1, identified in their stool specimens. The isolates in the 2 patients had no base pair differences. So when they did the whole genome sequencing, they basically couldn't tell the 2 isolates apart. An additional 6 patients were positive for Shigella enteroinvasive E. coli, for the target specifically, the IPA-H gene target. This could be suggestive also of Shiga toxin producing E. coli. There was STEC testing or Shiga toxin E. coli testing done on 2 of the isolates. They did not grow to STEC, so suggesting further that this was actually a Shigella infection. The state of Kansas put out a survey to those who visited the wildlife park, and 21 of 72 respondents who visited on the 11th reported illness meeting the shigellosis case definition. Getting splash pad water into the mouth was shown to be statistically significantly associated with meeting the case definition with illness. However, touching and feeding lemurs was not, because remember, we had to look at this because this splash pad was in a wildlife park, and lemurs can also be infected with Shigella flexneri. Of the survey respondents, 6 of 27 who visited on June 18th met a second definition. This case definition was for norovirus infection. 3 of those surveyed on 3 of the 6 surveyed who reported being in the splash pad on June 18th. Also reported being told by their healthcare provider they were diagnosed with norovirus infection. Additional patients who did not participate in the survey had laboratory evidence of being infected with norovirus, and they also went into the splash pad on the 18th. Again, getting splash pad water in the mouth was shown to be statistically significantly associated with meeting the case definition or becoming ill. This histogram here depicts illness onset by date, depicts date of visiting the wildlife park by illness. So for June 11th, we see all the cases that were met the shigellosis case definition. And for June 18th, we see all the cases that met the norovirus case definition. And you see for the other days, the light blue bars, so not the dark blue, which is shigellosis, or medium blue, which is the norovirus infections. But for all the other days, there were other days where people had illness, gastrointestinal illness. However, there were no primary cases for those other there were no primary cases with infection caused by Shigella or norovirus on those other days, and no pathogen was consistently identified for those other days. In terms of the environmental investigation, there was a microbiological investigation. They collected water samples at the splash pad on June 19th. They checked the sand filters for the splash pad, the pumps, the collection tank. They tested for Shigella and fecal indicator bacteria. Total coliforms were detected in 3 of the 7 pumps feeding the features. So what's actually spraying onto the users after it's been treated, and E. coli as well was detected in 1 of the coliform positive pumps. No Shigella was detected. In terms of environmental health investigation, the splash pad was unregulated. The water just basically sat in the collection tank, so where the water drains before it's treated and resprayed. So basically just sat there overnight instead of being continuously recirculated, filtered, and chlorinated. No staff member had documentation of completing standardized operator training, so they weren't really trained on operating and managing this splash pad. In terms of healthy swimming promotion, we take a 2-pronged approach with promoting healthy swimming. It's about making recommendations or policy approach, as well as a communications approach. So in terms of recommendations, in response to that second PAM case, CDC released recommendations for operators on how to operate and manage splash pads in a way that prevents Naegleria infection, and basically infection by chlorine-sensitive pathogens, because if you're doing good treatment of the water, you shouldn't be seeing PAM cases. You shouldn't be seeing Shigella cases. You shouldn't be seeing norovirus cases. We also put out recommendations for the public on how to use splash pads, checking out inspection scores before going in, not standing on the jets, not drinking the water. Joe Lako and I put out the next edition, or the 4th edition of the MAC, in February 2023 to also help with the design, construction, operation, and management of splash pads, pools, and hot tubs, and other aquatic venues open to the public. Joe's working on getting recommendations of running artificial swimming lagoons out this spring, and I'm working on doing so for surf venues. There aren't a lot of data to back up these last 2 venues, these lagoons and these surf venues. These are pretty new venues, but we do have enough data to say there's at least been 1 case of Naegleria infection associated with a surf venue. So we're working on getting those out. And in addition to getting recommendations out, we also work on getting communications out. So getting posters out, whether that be pool chemical safety posters for backyard pool owners, or for operators of public aquatic venues, videos, infographics, brochures, and chats. And that wraps it up for me. I want to acknowledge my colleagues in Kansas, as well as my colleagues at CDC. Thank you.
Dr. Clemens, would you like to proceed with your section of the webinar? Thank you. Dr. Clemens, you're on mute as well.
Okay, start with unmuting, and then let me see if I can figure out my share screen. Thank you.
We can see it. It looks good.
Great, thank you very much. My name is Tessa Clemens. I'm a health scientist at CDC working on drowning prevention, and I'm really grateful to have this opportunity to talk about drowning prevention as another important injury that can be prevented in recreational water settings. So I want to start by talking a little bit about the burden of drowning in the United States. And these data are based, the fatality data are based on death certificate data from CDC's National Center for Health Statistics. And hospitalization data are from other sources, including NICE AIP, which Michelle referenced in her presentation. And CDC, we also have a injury data system that's publicly facing. It's called Whiskers. And there are a lot of drowning data and information, both fatal and non-fatal in there. So just a quick plug that if you're ever looking for drowning information, you can see most of the things I'm presenting today in Whiskers. So there are over 4,000 fatal unintentional drownings in the US each year, and well over 8,000 non-fatal drownings. And we actually think that there are far more non-fatal drownings than that. And we're working on strengthening surveillance around non-fatal drowning in the US. For children less than 18 years of age, there are over 800 fatal unintentional drownings every year and almost 6,000 non-fatal drownings. So we really see a large proportion of the burden of non-fatal drowning in children. And non-fatal drowning is very important to consider when we're talking about drowning because it can result in long-term health problems and costly hospital stays. So for every child who dies from drowning, another 8 receive emergency department care for non-fatal drowning. And non-fatal drowning can also result in more severe outcomes than other injuries. So more than 40% of drownings that are treated in emergency departments end up requiring hospitalization or transfer for further care. And this is compared to about 8% for all injuries. So although non-fatal drowning might be a bit more rare of an outcome compared to other non-fatal injuries, like from motor vehicle crashes or falls or other things like that, when they do happen, they tend to be more severe. And I think something I really want to highlight that's often surprising to people is that drowning is the leading cause of death among children 1 to 4 years of age in the United States. And this is the single leading cause, meaning that drowning is killing more children in this age group than birth defects or motor vehicle crashes. And these deaths really are preventable. So this map is showing that drowning death rates vary by state. And I focused again on children under 18 years of age here, or 18 and under, I should say, because most of the drowning that occurs in recreational water settings is among children. So although there is also significant drowning burden in older age groups in the US, most of these happen in natural water settings, and I'll talk about that a little bit more on the next slide. But for 2016 to 2020, the overall drowning death rate among children under 18 in the US was 1.1 deaths per 100,000 children. And the states with lighter shading on this map have lower fatal drowning rates. The states with darker shading have higher rates. So those drowning death rates ranged from 0.5 per 100,000 to 2.3 per 100,000 population. And the states with the highest child drowning death rates were Louisiana, Mississippi, Florida, Arkansas, and Alabama. And again, this is focused on children. If we were to look at this map for all ages, you would see even higher rates in some states like Alaska and Hawaii. Alaska, for example, the crude fatal drowning rate is about 4.75 when we look at all ages. But a lot of those deaths are occurring among adults in natural water settings and often occupation related. So this map is more relevant when we're talking about recreational water settings. So drowning locations vary by age group. Infants less than 1 year are most frequently drown in bathtubs. And young children 1 to 4 most frequently drown in home swimming pools or private swimming pools. For children 5 to 14 years of age, it's about 50-50 between swimming pools and natural water. And the swimming pools in this age group certainly include a lot of home swimming pools, but also public recreational settings. So public pool drowning is more likely among older children than in the 1 to 4 age group, where it really is primarily private swimming pools. And then, as I mentioned, people 15 years and older most frequently drown in natural or open waters, either through swimming in open water or other boating related activities. So some people have higher risk of drowning. I've already mentioned children. Males are another high risk group. So about 80% of people who die from drowning in the US are male. There are also some racial and ethnic groups that have higher rates of drowning than others, and I'll talk about that a little bit more later in the presentation. Also, people with certain medical conditions, such as epilepsy and heart conditions, are at a higher risk of drowning. Deaths among children with autism spectrum disorder are nearly 40 times more likely to be caused by drowning as deaths in the general population. So there are a number of conditions that can really increase the risk of drowning, and a number of populations where tailored drowning prevention strategies are warranted. There are also some factors that further increase drowning risk. Not being able to swim is a key one, as well as missing or ineffective fences or other barriers around water sources, lack of close supervision of children, not wearing life jackets while boating, and drinking alcohol are among the key factors that increase the risk for drowning. So I want to talk a little bit more about racial and ethnic disparities in drowning rates. So in 2021, we published a study that identified that although drowning rates overall in the United States have been decreasing in recent decades, racial and ethnic disparities in drowning rates have persisted over that time. And overall, the highest drowning rates were found among non-Hispanic, American Indian, or Alaska Native persons, and non-Hispanic Black children and youth. The highest rates occurred among non-Hispanic youth in swimming pools, and I'll talk a bit more about that as well. So this chart is showing disparity rate ratios, and disparity rate ratios are calculated by dividing the rate in one group by that in another to determine how much more likely an event, so in this case drowning, is to occur in one group compared to another group. So for this study, we used non-Hispanic white persons as the reference population, and we chose this group because they represented the largest racial or ethnic group in the US during the study period. So a rate ratio that's greater than 1 indicates a higher drowning death rate in the specified group compared to non-Hispanic white persons. And conversely, a rate ratio that's less than 1 indicates a lower drowning death rate in a specified group compared with non-Hispanic white persons. And I should mention that this analysis was conducted for all people under the age of 30 in the US. And the reason that we chose that age group is that drowning is among the top 3 leading causes of unintentional injury death for each age group under 30 years of age. And this chart shows 5-year moving averages in disparity rate ratios. So we calculated the 5-year moving averages just to be able to visualize the trend more easily over time. So although it looks like the chart ends at 2018, it includes data through 2020, but just in a 5-year average. So using non-Hispanic white persons as the reference, the 5-year moving average in drowning rate ratios ranged from 1.8 to 2.2 for non-Hispanic American Indian or Alaska Native persons, which are represented by the purple line at the top of the chart, and from 1.3 to 1.6 for Black persons. So there was no significant change in the American Indian or Alaska Native rate ratio when you compare to white persons over the study period. So this high disparity, or the high rate ratio, remained consistent across that time. Whereas for non-Hispanic Black persons as compared to white, that rate ratio decreased significantly initially. So from 1999 to 2005, it appeared like that gap was narrowing, but then it increased significantly from 2005 to 2019 and has actually continued to increase since then. Overall, the drowning rate among non-Hispanic American Indian or Alaska Native persons was 2 times higher than for non-Hispanic white persons, and the rate among non-Hispanic Black persons was 1.5 times higher than among non-Hispanic white persons. So there are really substantial disparities by race and ethnicity when we talk about drowning rates in the US. Specifically, when we look at settings, as I mentioned earlier, the highest rate ratios occurred among Black youth in swimming pools. And so this was Black youth 5 to 14 years of age had rate ratios up to 7. So they drowned at rates up to 7 times higher than non-Hispanic white children. And the majority of these deaths are likely in public swimming pools. So the data source for this study is death certificate information, which doesn't specify private versus public swimming pools. So we can't say specifically when these were public recreational settings. However, we know from previous studies that Black children are more likely to drown in multiple unit dwelling pools or public pools than white children are. Compared to white persons, there were also disparities in swimming pool deaths for Asian and Hispanic persons in most age groups. So although overall, the disparities between Asian and Pacific Islander persons and Hispanic persons were not that great when compared to white persons, when we look specifically at swimming pools, those disparities were there for most of the age groups. So there really is an equity issue when we talk about drowning in swimming pools and in public aquatic venues that needs to be addressed. Fatal drowning rates in natural water were highest among American Indian or Alaska Native persons. So we also, in a separate study, looked at how fatal drowning rates in 2020 compared to previous years. And there was a lot of interest about this and whether the COVID-19 pandemic and different closures would impact drowning rates. So we did compare 2020 data to 2019. And what we found is that whereas drowning death rates had decreased an average of about 2% each year in the previous 10-year period, from 2019 to 2020, they increased significantly by about 16%. And the largest increases were among Black youth at about 24%. So again, those racial and ethnic disparities that have persisted over time may also be increasing in some groups, which is really concerning. And more work is needed to understand these increases, and specifically what factors, such as some of the risk factors that I talked about earlier, or other historical or structural factors might be contributing to increased risk for drowning in certain groups. The good news is that drowning is definitely preventable, and some of the most effective prevention strategies involve mitigating the risk factors that I described earlier. So drowning can be prevented by learning and teaching all children basic swimming and water safety skills, as well as building and maintaining 4-sided fences that fully enclose pools and separate them from any other structures with self-closing and self-latching gates. Designating a responsible adult to supervise closely and constantly when children are in or near water, including bathtubs, and ensuring that this practice is also in place in public aquatic venues, even when there is a lifeguard and even when children have taken swimming lessons. Wearing life jackets while boating can prevent drowning, and life jackets can also be used by children or weaker swimmers in any aquatic setting, as well as by people of all ages in natural water where there can be currents or other hazards that can quickly cause an issue even for the strongest swimmers. Avoiding alcohol before or during water activities and while supervising children. Some other strategies include learning CPR, knowing the risks of natural water, using the buddy system and always swimming in supervised settings with lifeguards and having adequate lifeguard coverage at public facilities, taking precautions for people with medical conditions. So for example, people with seizure disorders, when recreating in public facilities, that lifeguards and other supervisors that are with them are aware of that, and also to shower instead of bathe. And finally, to not hyperventilate or not allow patrons to hyperventilate in public pool settings, because this can cause hypoxic blackout, or sometimes known as shallow water blackout, when people try to hold their breath for extended periods of time underwater. So I just want to briefly mention CDC's role in drowning prevention. We use data to identify and characterize risks. So as I've mentioned, we're also working on a number of strategies to try to strengthen existing data. So where we aren't able to currently provide really detailed information about the setting itself where the drowning occurred, we have a number of projects that are looking at collecting that detailed information at the time of a drowning death and creating an ongoing database that will be able to be used for surveillance. We use the data that we do have to inform prevention strategies, and we provide technical assistance to states and other partners. And we also create and maintain partnerships to maximize our impact in drowning prevention. So our key focus areas, again, are improving drowning data and surveillance, with a particular emphasis on describing risk and protective factors in populations that are at increased risk of drowning. To identify and evaluate effective drowning prevention strategies. And our current focus has really been on basic swimming and water safety skills related interventions, and identifying how to effectively and equitably implement those strategies, particularly in communities that are at increased risk and have previously been underserved. So thank you very much for the time to speak with you today. If you're looking for more information or resources related to drowning prevention, you can check out our website, which is cdc.gov/drowning.
Dr. Clemens, thank you so much for your time. And Michelle, we have some questions in the chat, and we have about 8 minutes, so we will go through some of those. First and foremost, they're asking if you could please share the links in the chat. I believe those were the links from Michelle, your presentation. You had a few links in there. The second question is, will the slides be made available for downloading?
This is Michelle. I will put the links in, and I can send you a PDF of the slides, Christy, and you can just distribute.
Wonderful. Thank you very much. Our next question is regarding splash pads, and they've asked, in the splash pad cases in Texas, are these recirculating and not flow through designs? Do you have that information? Michelle and Dr. Clemens, you're both on mute.
Okay. The decorative fountain, the one from the 2020 case, was a single pass, which unfortunately is not addressed in the MAC. Single pass splash pads are currently exempt from the MAC. And the second one was the splash pad associated with the 2021 case was recirculating.
Okay, thank you. And we had a question of, I believe the graph was in your presentation, Michelle, and they're asking that your graph reported outbreaks through the NORS system, and it didn't have any outbreaks for New York State. And it seems unlikely that such a populous state as New York would not have any outbreaks. Is there an explanation for that?
Sure. So those data were It is my understanding that New York did not report any outbreaks when we pulled those data. I will say 2019 and 2020 data have been recently updated by our state partners. So the next time we report out a series of years, we will probably include 2019 again, just to update that, because there were reports that came in subsequently. I know that it was a challenge dealing with COVID, and we did note that in the limitations of the report. So, but yeah, that's a good point. We have talked about re-reporting the 2019 data because more reports have subsequently come in.
Thank you for that. Another question is, how has the pandemic affected the epidemiology of recreational water associated illnesses and injury?
Do you want to start, Tessa?
Yeah, so I think for drowning prevention specifically, we have published the one study that I briefly presented about that talked about increases in 2020. I think it's impossible to directly attribute them to the pandemic because there could be a lot of other factors involved, and drown rates do fluctuate quite a lot yearly, but they were also elevated in 2021. And we found the patterns changing a little bit. So there were a lot of increases in open water drowning. And we heard a lot of reports about people sort of heading when pools and things were closed, then they were heading to natural water settings during lockdowns and things like that. So we don't have enough information yet, and we're still working on different analyses to really try to understand the impact. But certainly we did see increases in drowning deaths in both 2020 and 2021.
Okay, the next question I have for you is, what emerging public health threats does the CDC foresee in aquatics in the future?
So if I just quickly could add with the pandemic effects on, I'll do that one first on recreational water in terms of outbreaks. So looking at the 2020 outbreak data, it looks like the only outbreaks we had were caused by Legionella. It looks like Cryptosporidium totally disappeared in terms of as far as being a etiology for these outbreaks. What we suspect happened is our state and local partners, when reporting outbreaks, prioritized outbreaks that resulted in hospitalizations and deaths. And so they didn't report the cryptosporidiosis outbreaks. We don't suddenly think that Cryptosporidium disappeared as an etiology. In terms of emerging threats to public health, in terms of aquatics from an infectious disease perspective, these new venues, I think, are a potential issue. The artificial swimming lagoon, where it's a half lake, half pool hybrid type of venue, and the surf venues where we're now trying to mimic the waves we see in oceans in an aquatic setting, in an aquatic venue. We've already seen one case of PAM associated with a surf venue. So I think these new ways of being exposed to water, are an emerging issue.
We just have a minute or so left. Is there any closing comments from either of you? And is it okay with the remaining questions that we have? We will send to the both of you. And maybe you could answer. Okay. Any closing comments, Dr. Clemens or Michelle?
No, thanks. Go ahead. Did you want to say something, Tessa? I just want to say thank you to our state and local partners. If you guys weren't doing these investigations and reporting these data, we wouldn't be able to analyze them and try to find points at which we can effectively prevent these outbreaks and these pool chemical injuries. So thank you to our state and local partners.
And we'd like to thank both of you again for taking time out of your busy schedules and joining us here at NEHA. And we thank everyone in attendance who attended this webinar. And if you would fill out the evaluation survey that we will supply to you, that would be greatly appreciated. And we remind everyone to join us again in 2 weeks for our second installment of the NEHA Recreational Water National Webinar Series. So good day, everyone, and thank you for joining us.